A training program, like the University of Zambia didn't offer it. A lot of them went and got trained elsewhere, like in the United Kingdom, and they didn't come back.
Oh, because they stayed there, huh?
Yes.
That
So they're like,
work.
there are more psychiatrists in Birmingham and Manchester, Zambian that is, than there are in Zambia.
I can understand that. Because it's much better.
Yes, it's much better, well appreciated, and then obviously the advancement as well. And that you have access to the drugs, and access to other specialists, like in the like a proper clinical psychologist. You've got a multidisciplinary team.
So where were you educated?
Educated, 3 different places.
But not here?
My first medical degree, I got in
First
Russia.
medical.
Yes,
Yeah.
in Russia.
In Russia.
In Moscow, yeah. The Russian People's Friendship University. And then the psychiatry I did here. So we were like the first intake of, psychiatrists that were being trained at the University of Zambia. Yeah, so a bit of both.
Okay, so how many degrees do you have?
Officially,
Bachelor, master's,
2.
MD, OD.
2. But then the University of Zambia separates, like undergraduate.
Right.
They give you a degree in biology, and then they give you a medical degree. So the ones who are here got 3. But at my university, it's 2. Yeah. So yeah.
But you came back from Russia?
It was
You didn't
cold.
like it, did
It
you?
was cold. It was freezing in Russia.
Wow.
Freezing.
So,
Really cold.
how long have you been here?
Chainama.
Mhm.
Let's see. I think about 6 years now. I could say. I joined in 2009.
But you've moved up to assistant director.
Pretty much. Yeah, pretty much. Somebody's got to do the job. The patients need to eat. Yeah. So and the nurses and the doctors need to be supervised. So somebody's got to do it.
How much help do you get from the government?
We do get a lot of help. We would want more, but yeah, definitely would want more. But I'd be lying if I said that they don't help out and they don't think of us. That would be very unfair, because the money that we get to run this hospital comes from the government. Yeah, we don't have other disciplines of medicines like the other hospital, the general hospitals. They get funding from stakeholders like the donor funds. So we're having actually, one of the reasons why I wasn't able to be with you this morning was because we're planning World Mental Health Day commemoration on the 10th of October. So I had to run around, see our permanent secretary, try and get funding for that and things like that. And get some other stakeholders who can donate whatever they can in order for us to commemorate, whether it's for the patients or it's for the actual day. So that's what I was running around trying to do. When Benjamin was like, oh, they're coming for suicide prevention, I was like, oh my God, that's good. We really need that. And just to keep the staff motivated, and it's always good to have, to get some learning and understanding from a different perspective as well.
Well, what type of diagnoses, if you were looking at the spread when they come in here, what type of diagnosis do you see?
The most common problem we are having is alcohol and related problems.
Okay. And now all the comorbidities that go along.
And the comorbidities that go along with it.
Okay.
But like
Alcohol what?
alcohol and related problems, like
related, okay.
alcohol dependence, abuse, and then sometimes psychosis due to alcohol.
Okay.
Sometimes they are using polysubstance like cannabis and alcohol is very common.
Okay.
Opiates, alcohol, cocaine sometimes.
Okay.
But the most common ones are the alcohol, and then sometimes there are comorbidities with primary mental disorder like schizophrenia comorbid with alcohol.
Okay.
bipolar disorder, comorbid with alcohol.
Okay.
So that's our major problem in the male wards.
Okay.
If you see almost 60%, 65% of our cases
Okay.
in
And
male wards.
in the female wards?
In female wards, we have got bipolar disorder,
Okay.
then HIV/AIDS related neuropsychiatric conditions
Okay.
are common among the females. They come with
In
that.
HIV,
HIV-related mental health problems.
and that's more common in the women than the men.
It's like they come more often than the men. Yeah, and then depression, major depression is very common among the females.
Okay.
Yeah.
Can you help us to, forgive me, what was your name one more time?
Nancy.
Nancy. Part of the purpose of us being here is to listen and to learn so that we know how we can best be of service. So we, at this point, just don't know what we don't know. So our questions are out of ignorance, basically. Explain to us how the country's perception is on mental health issues. If somebody out there needs to get help, how do they feel about coming to the hospital to get help or to see somebody in the mental health field?
I think what I'll say about the perception on the community, most of them, they have stigma. Because even the other time, one of the clients was saying that I had to struggle to come here. I was thinking Chainama is just something else, but I've realized that when I come here, I get help. So mostly they feel stigmatized coming here, but when they come here, they find that the treatment is good and the way they are handled, they are respected, and their rights are adhered to. So I would say the perception is about stigma.
Could you elaborate on what the stigma looks like? How does it play out? Or is it just within, from an internal perspective, or is it being ostracized from how others would perceive them from coming here? What does the stigma look like?
It's both self-stigma by the clients.
Okay.
Some of the clients, they wouldn't want to come until when they are very sick, and then we force them to come here. But also the community also has stigma towards the clients. So it's both ways, self-stigma and the stigma from the community.
Okay.
So I find that sometimes even when the clients come, like yesterday I was talking to one of the clients who was saying, I don't want to go back to the community because of the stigma which is there. I would rather you find someone to take me. So we had to refer her to the social worker.
Okay.
So it's both self-stigma and community.
So in the community, how do they treat them?
Yeah, it depends. Some of them, they accept their relatives, those who understand.
Yes.
But some of them, they understand, and some of them, they have lack of knowledge. And just the stigma, they will dump them, they will leave them here, and they wouldn't come to take them, and we have to repatriate them when they are discharged. So I find that sometimes they overstay in the hospital because their relatives, they don't want to come and pick them. It's like we own them. Sometimes when they are bringing them, they even say, we brought your patients.
Yeah.
Then we say they are not our patients, they are all your patients and our patients. But then they say, no, we brought your patients. It's like we own the patients. So we have to continue educating them and educating them on mental health problems. And we educate them that the patient doesn't come here to stay, he just comes to get treatment and he has to get back to the community.
Does that education only happen when somebody brings something to you, or is there anything proactive that's currently being done to go out into the communities to educate the communities now before somebody has to have a need for being here? What have you done that's been working and stuff like that?
Let me answer that. I think we have got some NGOs who are doing very good work in the community. Like there is one NGO called Mental Health User Network of Zambia. So they are like the patients themselves. They join that organization. So they are doing quite a lot of work.
So forgive me, are you describing what we would call, if I'm understanding, is like a peer support?
Yeah, you can say it's a peer support.
It's a peer, so mental health work.
Mental health users
Network of Zambia is a peer support group.
Yeah.
For people that have had mental issues.
Yeah.
And have come and gotten help and now are back in the community.
Exactly.
Now, are they the them and their families are involved, or just them that were a former
Both
client? Both. Okay.
Yeah,
So
they are doing quite a lot of work in the community, and they are very active, and they get some fundings from here and there.
okay.
So they are really very active in this country.
What type of work is it that they do?
But mostly it's the awareness campaigns, talking about the human rights for the patients, for the mental patients. They go all over, they will go to Ministry of Justice, they will go to Ministry of Health. They are quite strong. So they are doing a project currently. There is this for the people with disabilities. So it includes the intellectual disabilities and mental disability. And the project is on the legal capacity
Okay.
of the people with the mental health and intellectual disability.
Are they looked at by the powers that be in the government kind of like, I would say in my terminology is a lobbying organization?
Yeah, they are a lobbying organization.
Okay.
We call
Very
it
right.
advocacy.
Advocacy.
Advocacy, yeah.
Advocacy.
And they are all over when
Okay.
it comes to the mental health issues. They are included even when any meeting, like they are the mains, they are one of the stakeholders.
Okay.
Yeah.
So for change to happen in the country, they would be a major stakeholder.
Exactly, yeah.
Are there other stakeholders that would be of assistance with regard to making change?
Yes.
Who would
There-
they be?
There are other NGOs which are doing some work in the mental health, like there is an organization called Teen Challenge.
Teen Challenge, very familiar with them.
Yeah.
Yes.
So they are doing some
Okay.
programs for this alcohol rehab.
Yeah, I
They are
actually know
mainly church-based.
yeah, I know the guy in charge of the entire Teen Challenge here in the U.S.
Yeah. Then on the government organization, there is Drug Enforcement Commission.
Okay.
That's a government agency for the control of the drugs.
Okay.
So we work hand in hand with them. So they are also the
Okay.
stakeholders because they are the ones who arrest these people. With the cannabis use is also a main
Right,
problem here.
Right. Right.
So cannabis is illegal in this country.
Okay.
So people, they bring them here for counseling. They have their own counseling department also.
Okay.
But sometimes they bring the patients, and sometimes we send our patients for the
Okay.
rehab to them. So we work hand in hand. Then there is Human Rights Commission. That's
Okay.
also a government organization. We
Okay.
work hand in hand with the prisons. Then there is Zambia Federation of Disabilities.
Okay.
They are mainly working with people with disabilities.
Okay.
So we also work with them.
Okay.
Yeah, just yesterday we were having that meeting.
Does that include the intellectual and developmental disabilities?
Yes.
Okay. Now, is there, for lack of a better terminology, a single committee that all of these committees get together and discuss the issue at the same time? And they work together in a collaborative? Or do each one of them have their own focus on what their individual missions are and they just happen to intersect?
They have got their own missions, but where they see that this issue, like they have to involve the other stakeholders, so they always consult
Okay.
and we work in collaboration.
Okay.
I think I just wanted to add something on the stakeholders. I think it would be important to involve the family members themselves.
Yes.
Maybe we'll come up with a team of family members, because one of the parents for a client had said I would want to come up with an organization of people caring for the mentally ill. There would be important stakeholders.
Yes.
Yeah.
Yeah.
Our hospital, this hospital is a tertiary level hospital. It's a third level, fourth level actually hospital. But the patients sometimes we are seeing, they just come as first
Okay.
just to us because of the lack of the services near their homes. On the papers, there are clinics near every area in Lusaka, they have clinics.
So they can go to the clinic.
They can go to the clinic, but for the mental health services,
Got it.
the services are not existing in those clinics.
Okay.
So that's where the challenge is. So somebody with even the smallest of the problem will have to come to Chainama hospital.
Okay.
So that creates no problem for them, no transport, because if they are attended just near their homes, they don't need those transports and
Got
whatever.
it.
But for them to come here, yes, sometimes they miss their follow-up because of not having transport, and till they relapse, that's when they will come back. we have those challenges still,
Okay.
because of the poor economic status of the most of the people in this country.
And did they say this is the only mental health facility in the country?
This is the major tertiary level hospital. There are other facilities, like all the provincial hospitals, they have psychiatry departments. But again, this is the only place where there are psychiatrists and even the medical doctors in psychiatry. The other places are the psychiatry department are run by only the clinical officers.
Okay.
So which have just very basic training and not much knowledge.
Okay.
So they are the ones running. But now the government has looked into this
Okay.
problem, and they are sending some of us to at least the provincial level hospital.
Okay.
So like myself, I might be going to Livingstone, which is in the southern province, and I might go and be the head of the department.
So there's, if I can feedback so I'm understanding,
Yeah,
there's a client
yes,
that can go to a clinic.
yes,
The clinic can refer to a provincial hospital and or to Chainama Hospital.
yeah,
And if they go to the provincial hospital can also refer to Chainama
exactly.
Hospital. Okay. So,
But you see,
They
that,
cannot refer.
let me just come in. But the system is not existing. This, so the patients, they know that when they go to clinic, they will not be helped. So what happens? They come straight to us.
Got it.
Like especially those Lusaka-based patients,
Okay.
they will come. The referrals are mostly from the other places. Sometimes even the other places, people will know this problem is for Chainama.
Okay.
They will rather come straight to us than going to those places
Okay.
because they know the help. If the help is there, it's very little.
Magical. Magical.
So that's the problem. So the referral system, because people they understand that it's not really existing, because when they go to the clinic nearby their home, they will not be helped. They will still send them to Chainama. So to save that time, they come straight to us. So that increases our workload.
So, how many doctors do you have here?
We are about 10 here.
Okay.
About
Psychiatrists.
the psychiatrists, some are still under training.
Right.
Those who are qualified psychiatrists, currently we are 4
For the whole nation.
in this hospital. Yeah, you can say for the whole nation. There is one more who is leading the department at University of Zambia
Okay.
at UTH.
Okay.
Yeah, so otherwise these are
And the population we've been told is like 15 million? Is that correct?
somewhere. Yes, some of them will have a clinical officer, but not much work is existing there.
Are the nurses trained as psychiatric nurses or just RNs?
Yes, the nurses are trained as registered mental health nurses.
Okay.
Initially, what used to happen, we used to train as general nurses. Then afterwards, that's when we used to come to Chainama for in-service.
Okay.
So that stopped in, I can't remember whether it's 2003,
Okay.
somewhere there. That's when they started training direct entry, registered mental health nurses.
Okay.
But at first, we had enrolled psychiatric nurses
Okay.
who used to be trained from independence. Then after that, that's when they started training in service. But now we have direct registered mental health nurses. But
Okay.
for the hospital, we have 34
34. Okay.
registered mental health nurses.
Here?
Yes, 34, and then 20 enrolled psychiatric nurses.
Okay.
Yes. Well, it's the families who bring the people.
The
They
families.
take them to the general hospitals, then they'll be referred here. It's either they pass through the clinic, then the clinic refers them here, or they bring them direct, like Dr. Sheikh has already mentioned, because they know that if they have to pass to the general hospitals, they will still won't be taken care of, so they come direct here.
Right. So does an ambulance ever bring anybody here?
And they pass through the filter clinic.
So they have to go to the outpatient clinic
Yes,
first?
the filter clinic, that's where they'll be assessed, and then it will depend whether they need an admission or they just need medication, then they go back home.
Right.
So we have a filter clinic.
Do the police ever take anybody to the clinic?
The police.
Yes.
Yes, they do sometimes when there's an emergency, maybe somebody was aggressive out there or something like that, people will report to the police, then the police will come with that person to the filter clinic.
So they don't take them to prison. I think some people they have not They don't have the knowledge.
Okay, that's why I'm
Yeah.
trying to confirm.
Yeah, no,
Because
it's
that
not
changed.
criminal.
Okay.
Yeah, because we were specifically told that if they're at work or something and they say, I'm feeling very depressed and I'm going to kill myself, that they will call the police will come
No,
and
no,
arrest
no.
them, take them to jail
And
instead
not
of
take it
taking
out.
them.
No. It's not like that. The law is not like that here. Even committing suicide is not criminal offense. I can give you example, like I come from Pakistan. In our country, yes, attempting suicide is a criminal offense.
Okay.
So like if you make a suicidal attempt and then you survive, the police will definitely come and interview all those formalities you have to go through. But in Zambia, suicide is not criminal offense.
Either
So-
for ideation or for attempting. Or
Exactly.
Okay.
So mainly what happens if a patient will attempt suicide, they will go to University Teaching Hospital, which is the biggest hospital, the referral hospital in this country. So they will go there, for the emergency help, whatever.
So that's like a ambulatory acute care facility, UTH.
Yeah.
Okay.
So they will go there after the emergency treatment. Then there is the Department of Psychiatry for University of Zambia.
Okay.
It is based in UTH
Okay.
at Clinic 6 there. So they will go to that department and they get help, whatever counseling or whatever. Most of the cases for suicide, they go there. Para-suicide, you can say, those who survive.
Do you have, we would call it a 72-hour hold in the States. Is that what the treatment is here as well? If somebody's suicidal, do they get watched for 72 hours and then potentially released? Or what is the process if somebody has ideation but has not yet attempted?
Those who have ideation, they will definitely come here.
Okay.
We observe them. We don't have a specific ward for them.
Okay.
But yes, within the same ward, we observe them round the clock.
Okay.
Yeah, even more, not even 72 hours, maybe even more than that.
Okay.
We observe them until we find that they are safe now.
Okay.
And that's when, but we don't have a specific ward for suicide.
Okay.
They are within the same wards. The patients are there.
So the people who attempt,
Yes,
and they said they go to UTH, they go to the Clinic 6.
yes.
Is that inpatient?
There is inpatient, depending on what their condition is. Mostly like people here, they take this insecticides.
Mm-hmm.
It's very common for the people to take insecticide.
poison.
Insecticide
Yeah.
poisoning. That's what they usually use for, like suicidal attempts. Some of them they will cut and those, but they are few. Majority of the people, the means they use is through this insecticide or rat poisoning. Sometimes they use those rat poisons and what.
So we heard in the population, the top three would be overdose with regard to poisoning, hanging, and jumping off of towers. With the military, potentially it's guns.
Yeah.
Is that?
Here it's not, guns are not that common here.
Right.
So it's very rare you find that somebody has shot, extremely rare.
So would you say those three are also the same for the military? Poisoning, hanging, and
They just talk about the community. Because
Community.
there's no guns in the community. They don't have
There are not much guns here, like I'm sure you're talking about America, but here
Bring a lot
it's
of
different,
that's
yeah.
the number one method.
I understand, yeah. But here, you see the guns are not that common.
Yeah.
Mostly just with those criminals, and there are not many people who are criminals.
yeah, I was asking that question specifically with regard to the military methodology for suicide. That guns are not hot. The three methods of suicide for the community would be the same for the military.
Okay, I really don't, I'm not sure about military because they have their own hospital, like,
Oh,
so it's very rare they come to us.
okay. They have a whole nother system, like what you just described for community-based issues.
I think they have their own system.
Okay.
So it'd be better to find out from them.
Sometimes they consult us
Okay.
if they have any psychiatric issues and
Okay.
whatever. But most of their cases actually they're dealing with.
Okay, so what we've been learning from you does not necessarily mean it's going to be the same for the military.
Yeah,
Okay, got it.
but they have their own systems in place. Yeah.
Okay,
So we should be talking to the guy next week, right?
yeah. I
This is the
hope.
military guy should.
Yeah.
Okay. So poisoning, the way it's got poisoning by verse means poisoning by rope, which would be hanging.
Yeah, hanging is also there.
And they said a lot of people climb the towers and then jump from the towers.
Again, you see here they are building not very big buildings.
Yes.
Mostly
Is
it's
that
just in
why?
Lusaka. Other towns, I mean, you rarely find those
Okay.
big buildings like the ones you
Yeah.
find in America or other things.
Okay.
So again, that's
Yeah.
not that common.
Okay.
I don't know if I'm right.
Yeah, you're right. It's only in Lusaka.
Yeah, it's only in Lusaka
The
when
other
you.
places is the insect side.
Yeah, mostly
And honey.
because I know UTH because I worked there in that department.
Okay.
The most common means the people come with ingesting the suicide, some with paraffin, these kind of
Okay.
things, rat poisons.
Okay.
Those are
Oh, that was the. No, that was the word he used. Paraffin.
the battery
Nelson
acids.
was trying to tell us he couldn't quite get it out, but paraffin.
The
Yeah.
paraffin. Okay.
Battery acids also.
Oh,
Mm.
that'll hurt.
Yeah.
Okay.
Yeah.
Is there a central agency here for the country that all the facility statistics filter up to and are gathered at that looks at the entire nation?
You see, there is Ministry of Health. There is a mental health unit
Okay.
in Ministry of Health, but unfortunately, they are not very organized.
Okay.
because of there is no psychiatrist heading that place.
Okay.
So still we are waiting. There is room for improvement. Somebody must. We should have a directorate of mental health services. That's the plan in the future.
You're an organizer.
Yeah, that's not in place right now.
That's not in place currently. There is mental health unit. Ideally, they should have the stats. They have some statistics, but again, you may not find the whole statistic for them because Ministry of Health, since they are the parent organization,
Yes.
they should have the statistics for the whole country.
Okay.
And for other problems, they have the statistics.
Let me ask a question this way. If you, I would love to get both of your perspectives on this from a physician perspective. If you were to describe an ideal world where there were no roadblocks and you had everything that you needed, what would that world look like for the provision of care for your population?
Okay. I think if I look at this issue, I think we need to work on establishing our community psychiatry services because I think that's where we are lacking. No matter how much we are going to improve this hospital, because there are no plans to build a state-of-art new hospital and demolish this building totally because this is outdated and dilapidated infrastructure and we spend a lot of money on it. So in future, in next 4 or 5 years, you might see a totally new hospital. But again, we need to work on our community psychiatric services and we need to establish a working system where the patients are helped as near to their homes as possible. We need to do that.
What would that look like? If you could elaborate a little bit further.
You see, like we have got clinics, which are the primary level places where the patients, if a patient, let's say, has got an abdominal pain or he's got headache or whatever, they will go to the clinic nearby their homes. So we need to establish, even when somebody has got a mental health problem, the help should be available to them at that primary care level. That's where many problems can be just handled there.
Mm-hmm.
And if something is serious or is big, which they cannot manage, then they send it to the secondary level and then to the tertiary level hospital.
What would the nursing perspective look like at the provincial hospital level?
I think the ideal at the provincial hospital wants proper staffing levels. There should be adequate nurses to take care of the patients. And then adequate nurses. And then the medications. There should be enough medication so that they don't refer. Because if they are referring, they're giving us a burden here because we have a bigger number of patients. Because I don't see why the provincial hospital should be referring patients here if they have qualified staff there.
What would be adequate staffing of nurses at a provincial level?
At a provincial level, I wouldn't speak for them, but I feel probably, because I had worked at a provincial hospital, which is Cabo General Hospital, we just used to be, I think, about 5 nurses, but I think the ideal would be about 10.
10. Okay.
So,
About 10 for a provincial hospital like Cabo General Hospital.
okay, but how many patients per nurse?
Right.
Per nurse here.
The ratio, yeah. Is
I would,
where are you working now? Say if you're here, you said you have 35, was it 35 or 38
we have
nurses?
34 and 20 registered. But what I would say here, like today we have 56 patients in one of the acute wards, and we have only 2 nurses there.
So that's
So that is 1 to
28 to
28
1.
patients,
Yeah.
which is
Which
too
is
high.
quite bad for
And
the
there was a
patient.
time,
Yes.
there was a time when we used to have 1 to 50. 1 to 50 patients per nurse, which is too much. So even if you had to do your nursing care,
Right.
do your progress notes, your documentation, observation of patients, or nursing patient one-to-one, and all those, it's a bit of a challenge.
Okay.
So I think the main issue is the staffing levels.
Okay.
Yes. Well, there are some students, all the students are for degree nursing and from all the government schools and private nursing schools, they pass through here
Okay.
for their practicals. So during the practicals, that's when we try to educate them for the importance of psychiatry. So that as they go back wherever they're going to work, they should bear in mind that they can treat the patients. And then those who are interested, we usually encourage them that they should come here. Currently, we have 2 registered nurses who have shown interest and they are working here through the education which we
So out of your 34, how many are registered nurses?
We have 34 registered mental health nurses,
Okay.
and we have 2 registered nurses who are just general nurses and not psychiatrists.
Okay.